Okay, have all the nurses done the pre-test? Okay. My name is Bonnie Flemister. Some of you know me, some of you have worked with me. I'm a geriatric nurse practitioner. I've been working in nursing homes with people just like you for about 20 to 30 years. Okay? I know what you do. I don't live in some ivory tower and make up rules. And what I'm here for is to help you take better care of your residents. That's my whole purpose. I want you to please don't do any charting, no phones, no computers, no texting, and we'll get started. Okay. State gave you a tag, and it's F-684, and it has to do with quality of care for your residents and change of condition. This is all copyrighted. Okay, what we're going to accomplish today is we're going to recognize the early warning signs that are related to changes in condition so nursing can prevent a medical crisis. Now, what I mean by a medical crisis is something that the resident is so sick that they have to either go to the hospital or they die. We're going to talk about nursing knowledge and the skills that you're going to need and the abilities that are necessary for you to help these residents to keep them from getting sicker, and how to make some of those decisions. The nursing care plan has begun, of course. You all know when the resident is admitted to the facility. And the whole purpose of the nursing care plan is to give the kind of services to the resident that they either get better or they maintain the health that they have. And I know this is long-term care and sometimes that's not possible, but we absolutely do the best that we can to keep them as good as they can possibly be. And of course there's a written. Now, what is an acute change of condition? Okay, acute is the secret word here. Okay. And so what an acute change is it's something sudden. It's not something that's been dragging on forever. It isn't like they've had heart failure for 10 years and they get short of breath today. We're talking about something, a sudden change. And it's an important deviation from either how they think, how they're performing physically, or what their function is, how they're doing their chores. And without intervention, that condition may result in complications or death. See, we're talking about life and death stuff today. Okay. So any problem that's not in the plan of care, that in your best nursing assessment needs to be reported. And what we're talking about is, how does this happen? How long does it take? Well, sometimes it's abruptly. Just all of a sudden, someone has a stroke and they fall down on the floor and they can't move. Or it can be over several hours, meaning you notice a little change and then that change just gets worse and worse. Like maybe they're a little short of breath and then an hour later they're more short of breath and then an hour later they're really short of breath. Or it can be over several days. For instance, somebody's constipated, they haven't had a bowel movement, and then the next day they don't have a bowel movement, and the next day, and then we need to start paying attention. So how do you detect the change? You can't recognize a change unless you know the resident, unless you know how they're functioning. Sorry, I hit the wrong key. Transfers to the hospital often occur during the first month of admission. Okay? So we're not talking about residents who've been here for a month or been here for 3 months or 6 months or a year. The ones we need to watch are the ones that have been here a month or less. And the reason for that, why? Why do you think? Because we don't know them. We don't know what their baseline condition is. We haven't noticed how the resident moves around day to day. We don't know how the resident does with their activities every day. And we don't know the residents' preferences for their activities. How they want to eat, what they want to eat, what they want to wear. So changes in the resident's normal condition, what you're used to seeing every day, if there's a change, then that could be a sign that they're getting sick. So who's the first to notice? Well, it's usually the CNA. Their role is very important because they're the ones who see the resident most often. They're the ones that the resident depends on seeing what the differences are. The nursing assistants are the eyes, ears, and hands of the healthcare team. I don't underestimate who really sees that patient every single hour of the day. And the key is always in the watching. Nursing assistants must observe. You watch. Observe means you pay attention to what's going on. And then you have to report. Report and report. And any change that you see that worries you, okay, that's the least bit concern to you, you need to tell the nurse. Now the nurse needs to listen. Okay, they need to listen to the assistants. They need to listen to the residents, because when I became a nurse practitioner, one of the first things I learned was a patient will tell you what's wrong with them if you just take the time to listen. Now I know some of your residents can't tell you, but there are ones who can. You need to listen to the other team members. Never, ever underestimate the abilities of anybody else on the team, and that means housekeepers. And I was talking to them a little bit ago. If you really want to find out how a family member interacts with a resident, ask the housekeeper. Because they're the ones that are in and out, and they're the ones that see what's going on. And for some reason, family members, they may pay attention, whether there's a nurse in the room, they'll pay attention to the aides in the room, but a lot of times they just don't even see the housekeeper. So if you want to know what's going on, ask. A lot of times you need to pay attention to the people in the kitchen, because they can pick up stuff. They see those residents eating every single day. And you may be in the dining room, but you might not be able to see those little differences that they're pushing that food aside. Your activity coordinator is very important because she can see the differences in function. Somebody's playing bingo or being involved, and then they come in one day and they haven't got a clue what's going on. So the staff nurse who's assigned to the resident needs to recognize any condition changes early. That's the whole key, early. They need to assess the patient's symptoms and function and document everything that they see. Then they need to update the charge nurse or the supervisor if that resident's condition deteriorates. And then report the resident's status to the physician or the nurse practitioner. Observe. Now this is everybody. Just take time to look. Okay? You look at your resident, you remember that the exam or the observation starts the minute that you lay eyes on that resident. Okay? If there's any difference at all, from the last time you looked. The general appearance from way out. Sometimes I think it's really good that if you're going to check on a resident that you don't walk right in the room. You just kind of stand outside the doorway and look in and see how they're acting when you're not watching them. Because you've got some who will put on that they're really not doing well, and then you've got ones that will cover up. Okay? You see if they're anxious, see if they're more restless than usual. You need to see if they're more lethargic, they just don't have any energy today. Or, listen to me, something is just not right. Okay? That they're just not themselves. And I cannot tell you the times that we have headed off bad things because one of the aides or housekeeping or someone or a nurse came to me and said, I took vital signs, I've done everything I know to do, but something's not right. The first step is you say, is there a difference? And the key to the assessment is asking the question, why? Why is there a difference? And if you can figure out the why, you know what to do. Acute assessments, when an acute changes occur, you look for the possible causes. Why? You review any recent changes in the treatments and the medications. Has something been DC? Has something been added? And then you look at the labs. You review any changes in their activities of daily living. Are they doing anything different? Are they walking different? Are they sitting more differently? Are they doing something different in activities? And then you, of course, review their medical history. Why? You interview the resident as able, ask them any changes or concerns. Once again, you ask your staff if any changes. Everybody on the team, you ask if there's a change. And then you nurses need to conduct their assessment as determined as appropriate. You get your vitals, you get your mirrors, you listen to the lungs, you palpate the abdomen, you check the labs, you check with the aide or find out whether they had their last PM, when's the last time they voided. Is there anything different with the stool or urine? Their assessment includes vital signs. Are they different mentally? Are they less alert? What's their major diagnosis? What are their allergies? What's their current medication? What's the most recent lab? And what have you already done? Because there's no sense doing the same thing over and over again. And then find out if they have an advanced directive. Your vital signs. We're taught in nursing school that vital signs are important and that pulse and respiration and blood pressure and temperature are essential to identify what's going on with the resident. But I'll tell you that research shows and study shows we don't do that. We don't do it as frequently as we should. We don't document them, and we don't pay any attention to what went on before. The lapses interfere with appropriate care, and one of the problems is we call them routine vital signs. And the thing that you need to know, that a lot of times vital problems can be caught up and haven't been caught 24 hours before somebody dies. I'm sorry, I'm having a hard time with this. So take your vital signs. The reason because they're called vital signs is because they're vital. They're important. They tell you how sick or how well someone is. They can help you identify the medical problem. A rapid measurement of the severity of the illness can tell you how the body is coping. Your vital signs tell you how the body is coping with any change. And then what you need to know is the bigger the difference comparing these vital signs to previous vital signs will tell you how sick the resident is. The bigger the difference, the sicker they are. So the physician notification, there's immediate and there's non-immediate. And immediate means you need to get on the phone right then, or the beeper, or whatever you contact them, and you do it right now. And then non-immediate means that the nurse or the physician or the nurse practitioner can be informed of the problems or events during office hours and generally no later than the next day. Change of condition. If there's an alteration in the mental status, okay, and I've had docs say this to me, they're forgetting things, their mentation it's bad. They say, well, how did you got the mention? Yeah, but there's a difference. We know there's a difference, okay? So any change, sudden change in the mental status means you need to notify the doctor immediately. Change of condition, we're talking about temperatures, oral temperatures or rectal temperatures. Anytime you've got one of these folks with a temperature of 100, and even though the parameters say 101, if they've got a temperature of 100 or any temp with chills and the tremors, the doctor needs to know, okay? Because our older people don't get temperatures like little kids do. When their temp goes up, they're sick. And if they've got fever, chills, and tremors, they're really, really sick. Change of condition, glucose, anything less than 40, anything more than 400, or you might have a doc who's giving you parameters of when to call, okay? Anytime that somebody's consistently having glucose readings over 200, the doctor needs to know and be reminded. Change in condition, skin breakdown. Those of you who know me know I'm also a wound nurse, okay? So any new skin breakdown, any increase in drainage of a wound, any increase in odor, any increased pain, if there's redness around the wound greater than 1 inch, okay, or a change in the color of the wound bed, if it goes from pink and red to yellow or gray or black, that's an immediate call to the doctor. And then a non-immediate, but it's still notification, is if you've been treating that wound for 2 weeks and there's no change, you need new orders. Change in condition, chest pain. What?
I just got you some water.
Oh, okay, thank you. New onset. Thank you. Or any pain that's not been relieved by nitroglycerin 3 times, or accompanied, any chest pain that's accompanied by sweating, by nausea and vomiting, or really shortness of breath, needs reported. If they've had a known history of chest pain and you can give them nitroglycerin and it goes away, that's a non-immediate. Chest pain can indicate lots of things, okay? It can be anything from heart to your belly, okay? But any pain in the chest, arm, neck, with any shortness of breath, sweating, sudden change in mental status, or sudden weakness is call the doctor right now, okay? Change of condition, resting pulse, anything over 120. If it's accompanied by shortness of breath, or sweating, or any, a lot of times you have to look really closely, they look kind of pale around the mouth. It's called circummoral pallor, or circummoral cyanosis. They get blue around the mouth. Call the doctor right away. And I'm talking about residents here, but each of you have family members. Oh, that's okay. Each of you have family members. And you can pay attention to these things with your family at home and keep them from getting really sick. Respirations, the normal range is between 12 and 28. You have to count for at least 30 seconds and preferably a minute. And then they're not particular in a routine exam. They're not very helpful, but they sure can help if you're worried about someone having a stroke or whether they're having a heart attack. Changing condition, respirations, if they've never had rapid shallow breathing before, anything over 28 or anything less than 10. A pulse oximeter, this can be your fifth objective vital sign. Systolic blood pressure, anything over 200, anything less than 90. Diastolic, anything over 110, anything less than 40. Or a non-immediate would be a diastolic of 90 consistently for a couple days. Change of condition, edema, this one's important, okay? If you ever have a resident, especially one who comes in from the hospital that they've been not having much activity, if they start getting swelling in one foot or one leg, you pay attention because they probably have a blood clot, okay? Now, if it's both legs, okay, then it's sudden and they have shortness of breath, they're probably in heart failure. Okay. Now, if someone has a known history of swelling in their legs and you know they have congestive heart failure, then you can watch it, but then please report it the next day, especially if they're gaining 1 or 2 pounds more. You always compare the vital signs to the previous set. You can't tell if there's a difference if you don't pay any attention. And even though I know the aides don't take vital signs here, there's nothing wrong with you looking at them to check. And there certainly isn't anything wrong with you saying to the nurse, there's something not right, will you please take vital signs? That's a good aid. I'd be tickled to death if an aide came up to me and said that. Vital signs provide valuable information. There's a lot of things that can indicate. You have to take those vital signs and pay attention to what the medical condition is, what your nursing diagnosis is, and pull that all together. That's called critical thinking. To make an informed decision, the physician must have a set of vital signs. Never, ever call a doctor when you are worried about something unless you have a complete set of vital signs. It makes them slap dab crazy. And then your nursing responsibility is to give the physician your assessment of signs and symptoms. They can't do what they need to do unless you give them their information. They're usually on the other end of the telephone, and the only way they can figure out what's going on is if you're telling them. The physician is responsible for deciding what the medical problem is, but they can't do it unless you give them the clues. When to report lab? When you report lab, if it's outside any parameter the doc gave you, it depends on the doctor whether you're going to call or fax. Always compare previous lab to the lab that you're holding in front of you. If it's critical, call right now. Call right now. Call if there's an abnormal WBC, a PTINR, or cultures that need an antibiotic. And then always assess the resident for signs and symptoms. Problem identification. If you get your assessment, you know what the problem is, The next step is for the nurse to complete planning with input from the other providers. And then it'll focus on what's the outcome? What do you want this to happen to this resident? Okay, how do you want them to get better? And then does the plan compare with existing plan of care? Now, sometimes you can actually predict what's going to happen. Okay? If you've got a resident with an infection, then you can pretty much count on they're going to get delirious, and if it's a diabetic, their blood sugars are going to go up. Okay? If they've had a catheterization in the hospital, they're going to probably get a UTI, so you watch out for the fever and you pay attention to that urine. If there's a change in medication, especially blood pressure medication, they're going to fall. They're going to fall. Pay attention. And then post-surgery, infection is the most common cause of complication days or weeks after surgery. And that's what y'all got dinged on, okay? So post-surgery, you need to inspect and assess the incision. You need to pay attention. If it's warm to touch, now y'all, there is no way that you can tell whether a wound is warm with gloves on. Okay? So if you're really, really worried about it, take the gloves off, wash your hands, use your alcohol, feel around that wound, and then if you've been prepared, you use alcohol again and put another pair of gloves on right there. Okay? But always when you take those gloves off, you wash your hands, but for heaven's sakes, use the alcohol and put gloves back on. Okay? The other thing is it feels firm to touch. If you feel over here and then feel here, there's a difference on how firm it is. Is there increased redness? Anything more than an inch? Is there increased drainage? Is there increased pain? Mine go to absolutely positively. If there's increased drainage or there's increased pain, you got an infection coming on. Okay? Because if you think about it, if you've got a wound, it's supposed to drain less and it's going to be less painful. Okay? So if you have an increase in those, you've got a problem. Remember, UTIs are common after surgery because they've been catheterized. Pneumonia is pretty common because they've been laying in bed and not moving around. Okay, so pay attention to the cough. They've got diarrhea. We all know what C. diff is. Okay? And you bet they probably had antibiotics in the hospital. Okay, the resident should feel better, a little better each day. Okay, they should feel better each day. And if they're not moving around as much and they feel lazier and don't want to do things, there's a problem. The nursing evaluation did what you did, whatever intervention you did it work? Okay, did it work? If it didn't, fix it. Documentation, you need to write a detailed nurse's note describing what the change is, along with what you did about it and what happened. Interventions can be as simple as giving a PRN bag. It can be as simple as repositioning because they're in pain. It can be a notification of the doctor. It can be implementing new orders. It can be transferred to the hospital. So, who needs notified? The director of nursing. Do you know how? Do you know when? You need to notify the administrator. Do you? How? And when is it necessary? You notify the family. How do you notify the family? When do you notify them? The physician, how and when. Those are the things that you really need to have nailed down. Nurses should never, ever hesitate to contact the physician at any time for a problem in their best assessment that requires immediate attention. And I'll tell you a personal story. I was working in ICU, and I had a patient go into an irregular heart rhythm, VTAC, ventricular tachycardia, which is life-threatening. And I called a doctor who I really liked, and I said, "Doctor, I think your patient's in VTAC." And he said, "Well, Bonnie, it is even." Why is he questioning me? He knows how good I am. And I said, "Well, I think he is." So he said, "Okay, I'll be there." So he came over to the hospital, and the patient was in VTAC, but that's not important. The important thing is what came next. He was really, I can tell he was irritated. And I went up to him and I said, "You know, my purpose for today was not to irritate you. And so I know you're annoyed with me, but if you'll just tell me what I did, I'll really try not to do it again." And he said, "Bonnie, I want you to listen to me. What is the difference between I think this patient's in VTAC and in my best nursing assessment, this patient is in VTAC? In my best nursing assessment, that means I looked at the monitor, I checked the patient, I did everything I was supposed to do, and in my best nursing assessment, I called him and told him." Okay, so what I'm telling you is, if you do an assessment of a resident, and putting all those pieces together, in your best nursing assessment, it doesn't matter whether you're right or wrong. You're giving the information to the physician for him to make the medical diagnosis, and now it's his or her problem. Do you hear what I'm saying? And I promise you that if you ever have to call a doctor and you say, "In my best nursing assessment, this is what's going on," you got it made. There's no way you can be criticized. So now if you really are unsure of when to call and there's no one with more experience to ask, put on that samurai invisible armor and call the doctor. I don't know what your docs are like now, but anyway, if you get fussed at, it's better that you got fussed at than not to get fussed at and have your resident go bad. So when in doubt, report a change. And that goes for aides and anyone that's in housekeeping or in the dietary. Okay, if you think there's a problem, say something. So nurses, when you notify the physician, for heaven's sakes, get all your information together in one place. Okay, make sure you got the chart, you got the medication list, you got the vital signs, or any lab that's available. Anticipate, your doctor's going to ask you questions. Get ready for those questions. And docs most of them are going to ask the same ones each time, don't they? Yeah. And then, if the doctor has to return the call, for heaven's sakes, be available. Or tell whoever's at the desk where you're going to be so they can get to the phone right away. Acute changes must be reported by telephone. You can't fax them, because you don't know when that fax is going to get received or if it's ever going to get picked up. When you call, be sure to say what facility you're calling from, who you are, and what the physician is, or who the physician is, because docs know what the other docs usually do. And it makes it so much easier for them, since they know what the other doctor would do, to just do it too. Okay? And then if it's an emergency, contact the hospital emergency room, but remember you have to have a physician's order to do that. Wink, wink. Nurses, you need to monitor and reassess the resident's status relating to the plan. You need to know what to expect. You need to know what to monitor. You need to continue until the problem is solved. Okay? Just because things aren't working out the way you thought they would, you stay with it until the problem's solved, or until if there's no resolution, you keep on with the contacts and you keep on with the interventions. The doctor has responsibilities too. It's his patient. Remember that. It's his patient. So he needs to develop the diagnosis. He needs to guide the nursing staff. Okay? He needs to guide you. You're not doctors. He needs to tell you what to do. Maybe not how to do it, but what to do. You need to know what to expect. If he orders LASIK, then you need to know that he's expecting that patient to put out a lot of urine. Okay? You need to know what to monitor. If you're calling about heart failure, you need to know, do you want me to watch for shortness of breath? Do you want me to pay attention to how much output? What is it you want me to watch? And then when to call the doctor back if things aren't going the way they should. And there's nothing wrong with asking that question. If I do this, if I give the LASIK and the resident doesn't begin to void, when do you want me to call them back? Okay, you document the resident's chart. You document any attempts that you contacted the physician. You document the physician's response. And this one I want you to listen to. Your job as a nurse is not to cover up for doctors. If that doctor says, I don't care, don't call me back. You document it. The physician said, don't bother me, don't call me back. Okay? He's got his own insurance. You are not it. And then you document any physician's orders, and you document the resident's status and response. Document if the resident remains in the facility, a change of condition has occurred, and you need to update the plan of care. To document the circumstances surrounding the change in condition, what led to the transfer to the hospital, and then chart all the interventions. What time did EMS get here? When did they pick up the patient? Don't forget to obtain the physician's order, and always notify the responsible party. Remember to do the transfer form. Please, please, please do something about it. If they have a DNR, make sure it goes with them. There have been several lawsuits lately because residents had DNRs and they didn't go to the hospital, and the hospital resuscitated them. And the family sued the facility. Okay. They need a list of the medications and the most recent history and physical, which we know is 50 years old. Okay, if they're readmitted from the hospital, this is a change in condition that needs another plan of care. You review carefully the admission orders. Are there changes? Did they come back with any change in the DNR? The other thing is the meds. This is the number one cause of problems, is the meds going into the hospital and coming back. One of the things you need to know is that in the hospital, drugs for dementia are not on the formulary. So what happens is they DC the Aricept. I'm just using that for example. And so when they come back from the hospital, they don't have Aricept on their meds. What you need to know that each day that resident is without their meds for dementia, they will decline, and they never ever get it back. Okay? Whatever they declined without the meds, they don't get it back. So if you know your resident was on meds for dementia, and they come back in and it's not on there, call the doctor and get a new order. Okay? If that's appropriate for that resident, it's up to the doctor. But any kind of medication for a chronic disease, and they come back from the hospital and it's not on their meds, you need to check. Okay? You assess for new wounds. You gotta do the brain, and then check if they went into the hospital with the wound, and they come back, it's gonna be worse, isn't it? Mhm. Okay, then you get your new wound care orders. The key lesson, everything we've talked about today, is learn to recognize any change early. Early. Not reporting a change can lead to other things going wrong. And it usually is downhill. And then the sooner something is done, the better it's going to be for the resident. And that's why we're in there. Any questions? Thank you for your time. And thank you for your attention. And now take your post-test. Now the post-test is exactly what the pre-test is, and I'll go over it with you. And then I think those of you who aren't taking the test can go. Bye.
What?